So I'm going to talk today about defining general anesthesia. What do we target? When I was 2 years ago at the ASA meeting, I saw this slide and this description of general anesthesia by Giulio Tognoni, who gave the John Severinghaus lecture there. And he said general anesthesia is the merciful annihilation of consciousness. And I think that's an excellent description of what general anesthesia is about. A bit more scientifically, general anesthesia can be defined as a reversible pharmacologically induced state where the patient is unresponsive to a wide range of stimuli. What are the components of general anesthesia? The first and the most important component of general anesthesia is unconsciousness, which is synonymous with hypnosis. It means that you're aware of oneself and surroundings, you're unarousable. We want this to occur in 100% of our patients, and it's really the primary goal of anesthesia. But what is unconsciousness? If we ask this question, we have to also ask the similar question, what is consciousness? There are several people here with a special interest in that. Consciousness is awareness of oneself and surroundings. It's being able to be responsive to the environment. You are perceptive, you're awake, you're vigilant. Your ability to experience or feel, it's the state of being aware of an external object, state, or fact. And it's an executive control system of the mind. But what is required to be conscious? Again, Tognoni has a very nice theory about this. It's the integrated information theory. What that means is that if a stimulus reaches the brain, like you see here in this wide plus sign, the stimulus can reach the brain, but if you're conscious, that stimulus will transfer to other areas of the brain. The information has to be integrated in all areas of the brain. And in an awake patient on the right-hand side, you see that after the stimulus reaches the brain, lots of other areas of the brain become very active very quickly. So there has to be connectivity to these other areas of the brain for that to occur. And that theory is called the integrated information theory. On the left-hand side, you have an image of the brain where the stimulus still reaches the cortex of the brain, but there is not a whole lot of activity around that area where the stimulus reaches the brain. In other words, the connectivity is lost, and therefore the information that reaches the brain cannot be integrated anymore. And you're not really aware of what is happening, of that stimulus. You're unconscious. The second component of general anesthesia is immobility. The immobility that we require from general anesthesia is more relative because it really depends on the procedure. For example, if you do a knee arthroscopy and the patient starts hiccuping, your surgeon will not complain. However, if the surgeon is doing peridiaphragmatic surgery, then he will complain because it will interfere with his activity. So it really depends on the kind of procedure that you're doing. For example, when you do an intracranial aneurysm clipping, you really don't want to move at all when the clip goes on. We go as far as with coronary bypass surgery to immobilize the heart even. So the requirement for immobility depends on the type of procedure that you're doing. So, and the goal here of general anesthesia is to provide immobility to such a degree that the procedure can be performed. The next component of the general anesthesia is autonomic reflex control. But this time, this is really dependent on the patient's condition. What we want to do is avoid hypertension and tachycardia, but lots of patients can tolerate a short episode of tachycardia and hypertension. If I intubate a healthy 20-year-old who is no other medical issues, during intubation, if the heart rate goes up to 120 and it only lasts for a couple of minutes, nobody will care about that. However, if you do this in a patient with severe coronary artery disease, a left main lesion, or with severe aortic stenosis, that's a big no-no. So you have to control the hemodynamics to protect the patient. Again, it's relative. It depends on the patient's condition. And the final component that I added to it has to be reversible, and preferentially fairly quickly. Are there other components of general anesthesia? What about amnesia? I think amnesia is irrelevant when you're unconscious. If you're not aware of the surroundings, there is no conscious perception of what's going on, how can you remember it? In other words, amnesia is built into unconsciousness. It's an integral part of unconsciousness. How about pain? How about analgesia? I think pain is a conscious sensation, conscious experience, and therefore when you're unconscious, there is no perception of pain. So almost by definition, there is no pain when you're unconscious. However, there is nociceptive stimulation that frequently, not always, results in a sympathetic response. That can be blocked, that sympathetic response can be blocked at many levels. That can be blocked by local anesthetic in the area where the surgeon is providing the noxious stimulus. Can be treated by more inhaled anesthetics. You can give intravenous agents. Opioids, of course, are very effective in that regard. But you can also use beta blockers or vasodilators. So the sympathetic response as a result of nociceptive stimulation can be taken care of in many, many different ways. What way you choose depends on the patient's condition and many other factors. There are other aspects of general anesthesia that I'm not really going to discuss today, and these include hormonal stress response, immunologic response, and inflammatory response. So we have these four components of general anesthesia that I briefly discussed, and now the question is, how do we achieve these goals during a general anesthetic? We can do that by using inhaled anesthetics. We can choose intravenous anesthetics, DIVA, which is usually a combination of a hypnotic and an opioid. Or we can use balanced anesthesia, which is a combination of all of the above. Potent inhaled anesthetics now can usually ensure all components of general anesthesia in most patients in and by themselves. So frequently you can provide an anesthetic by only using the potent inhaled anesthetic. When you use intravenous anesthetics, however, combination with opioids is kind of standard. And the reason for that is that when you look at this response surface model, where you have a hypnotic, an opioid, and on the vertical axis, the probability of non-responsiveness, if you only use a hypnotic without opioid, you will see that you will need fairly high doses of your hypnotic in order to achieve non-responsiveness, and actually you can never achieve it in 100% of your patients. You will achieve it in maybe 75, 80, or 85% of your patients. If you add an opioid now to your intravenous hypnotic, then you will see that you will need lower concentrations to achieve your goal. There are two isoboles on this graph. This is the 90% probability of non-responsiveness, and the middle line here is 50% probability of non-responsiveness. So again, hypnotics, intravenous agents are usually combined with an opioid to reduce their plasma concentration. I'm not really going to talk a whole lot about the mechanisms of action of potent inhaled anesthetics, except to say that they are working in the CNS, and unconsciousness is in general provided at the level of the basal nuclei and cerebral cortex, while immobility is in general achieved by action at the level of the spinal cord. Eager has done a lot of work and has helped us a lot in facilitating communication by introducing the concept of MAC. MAC is the minimal alveolar concentration. It's the alveolar partial pressure that prevents motor response in 50% of the subject in response to a surgical stimulus at steady state. It should have been called median, not minimal, and it should have been called MAC immobility, because later on we introduced other MACs, the expanded MAC concept. It has been determined in volunteers who were unpremedicated, who were fasted, 20 to 40 years old. They were healthy. They were all males. So MAC was determined in this kind of a healthy patient population. We now have the expanded MAC concept, where we have other endpoints after giving potent inhaled anesthetic, and these include amnesia, awake, immobility, and MAC-bar, block autonomic reflexes. In the beginning, I said that as a definition of general anesthesia, it's a reversible pharmacologically induced state where a patient is unresponsive through a wide range of stimuli. And that has been built into the MAC concept and expanded MAC concept. We have the verbal command that has been linked to a proper response by the patient. We have the skin incision, which is usually related to the response movement. And the stimulus here is intubation, and that is related to sympathetic response, which gives us MAC-bar. So all of these dose response curves have been grouped into this kind of a slide where we talk about MAC awake, MAC, MAC-bar, and again we are talking about the 50% probability of non-response or response. And we see that the slopes of these curves are fairly steep. In other words, you need only slightly higher concentration than 1 MAC in order to achieve immobility in 95% of your patients. And the same is true for MAC awake and MAC-bar. So we really want immobility in not just 50% of our patients, but we want it in 95% of our patients at least. And that's where 1.3 MAC has been determined to provide immobility in those 95% of patients. So if you go slightly above 1 MAC, you have a non-response in many more patients. In other words, the curves are pretty steep. This slide is very similar to the one I showed 2 slides ago, but this now includes a better illustration of the difference on stimulus that you apply and the difference in response that you're looking at. So in this part, you look at MAC awake, which is a response to a verbal command and the probability of response. In this part, you look at the response to an incision, and in this part, you look at the response to intubation MAC-bar. And with each increase in stimulus intensity, you look for a different endpoint, but you know that the concentration of your inhaled anesthetic has to be higher also. Now for MAC unconsciousness, we know that we want unconsciousness in 100% of our patients if at all possible. We want it at 99.999% of our patients, and to achieve that, we need more than 1.3 times MAC awake. But we need 2 times MAC awake. That has been suggested by Eager, and he said that if you achieve 0.7 MAC and tidal anesthetic, your patients will virtually guaranteed be unconscious. There has never been a case report where a patient was found to be aware during a procedure when the anesthetic level at steady state was at 0.7 or higher MAC. I also mentioned that potent inhaled anesthetic can ensure all components of general anesthesia in most patients in and by themselves. But does that mean that we don't need opioids during general anesthesia with potent inhaled anesthetic? Absolutely not, because opioids do reduce anesthetic requirements, the requirement for your potent inhaled anesthetic, and that has significant pharmacokinetic advantages. The advantage that I'm talking about here is rapid emergence. So for rapid emergence, we want several aspects, or we want several capabilities of our anesthetic. We will want low tissue solubility. We can speed up emergence by using isocapnic hyperventilation, because if you hyperventilate, you get rid of the anesthetic faster than if you normoventilate. You can try to avoid prolonged anesthetic so you have less buildup into the body of your anesthetic. Of course, that's not our choice. And finally, you can reduce maintenance FA by combination with an opioid. Because potent inhaled anesthetics have also context-sensitive decrement times. That has been described very nicely in this article by Eager and Schaefer. And the decrement times depend not just on the duration of the anesthetic, but also on the tissue solubility. And if you look here at the 90% decrement times, which means that concentration in the vessel-rich groups go to 10% of the original value. You see that the time, the minutes to have a 90% decrement is much longer for isoflurane, and it increases with the duration of the anesthetic for all agents. The best anesthetic with the shortest decrement time is obviously desflurane because of its lower solubility. To illustrate that, if you maintain an anesthetic at 1.3 MAC and you want to wake up the patient, you want to go to 0.35 MAC, which is MAC awake, and that gives you a 50% probability of your patient being awake at the end of the procedure. If you maintain the anesthetic at 1.3, that means that you need a 73% decrement. If you use 0.7 MAC as maintenance, supplemented with opioids, and you want to wake up the patient, you still have to go to the 0.35 MAC. Close but not totally correct. You only need a 50% decrement. In other words, if you maintain the anesthetic with 0.7 MAC plus opioids, you will have faster emergence. How do we do that with the intravenous anesthetics? We rely on fast metabolism and a large volume of distribution. We get rapid emergence after short procedures. Again, that's not our choice. And if we can reduce the maintenance plasma concentration by combining an opioid, then we will speed up emergence. So the opioids inhibit ascending nociceptive pathways, thereby reducing the concentration of hypnotics required to induce unconsciousness, immobility, and hemodynamic stability. So it's the inhibition of the ascending nociceptive pathways that is so important when we use opioids. We use pairs of stimulation responses. In general, the stimuli that we use for inhaled anesthetics are verbal commands, skin incision, and intubation, and the responses are those well known already. While for TIVA, the studies have been slightly different. We use many more stimuli than have been classically used for inhaled anesthetic, and also we use many more responses. We are looking for more responses. And frequently, studies are done where you use one stimulus and you look at a number of different kind of responses. So the typical patient study for intravenous agents has been somewhat more complex for potent inhaled anesthetics. So here you see a slide where you have an increasing depth of or intensity of stimulus, going from light stimulus to more severe stimulus, and you have different kind of responses that you can look for on the axis. And this arrow indicates that you're going to get an increased depth of anesthesia if you want non-responsiveness to more intense stimuli. So I make a plea for using opioids in combination with potent inhaled anesthetic and obviously with intravenous anesthetics. And this is not to treat intraoperative pain, because there is no pain during general anesthesia, but it is to reduce the agent concentration so that you can achieve faster emergence. So what now is the effect of opioids on MAC awake, MAC, and MAC bar? We usually say that the opioids have a MAC sparing effect, but I don't think that's really a correct term, because MAC has been a fixed number, and that's based on the studies in healthy volunteers, 20, 30-year-old males. So MAC is a fixed number, but we should say opioids reduce the alveolar partial pressure that's required to block the response to certain stimuli. I think that's what we should be saying. Still, everybody using the term MAC sparing effect of opioids, it's ingrained in our brain, and that's what we're going to continue to use, but I don't think it's really a correct term. Cato in the 90s has done several studies where he looked at the effects of opioids on MAC awake, MAC, and MAC bar. And this is a combination slide of several of his results. Here you have MAC awake in the left upper corner, and the left lower corner is a detailed part of this same slide. And it's just for 0 to 2 nanograms per ml fentanyl plasma concentration. Here we see the effect of opioids on MAC, and here we see the effects on MAC bar. In general, a 2 nanogram per milliliter fentanyl concentration is a clinically effective dose that results in appropriate initial postoperative pain control. So that's a concentration that we frequently aim for during general anesthesia. And we see that in terms of MAC, we have about a 50% reduction in the MAC in the MAC requirement by the use of 2 nanograms per ml fentanyl. If we look at MAC bar, we see that the reduction is even higher, 75% at the 2 nanograms per ml fentanyl concentration, while we see that MAC awake is only slightly decreased in the presence of that concentration of fentanyl, only 15%. So opioids have much more of an effect on reducing MAC bar and MAC than on MAC awake. This whole concept have been described in this kind of a slide also, and this one was presented in the latest Miller edition, where we have different kinds of stimuli, different kind of responses, and the probability of the surface responses that display the probability of a non-response for several combinations of your hypnotic and opioid. And you see that the height here is higher to indicate that the stimulus is more intense. But again, what we are not really interested in is the 50% isobo. Here, for example, the 50% isobo. But we want a non-response in at least 95% of the patients. So we are really more interested in the 95% isobo. What is the issue with using lots of opioids now? The issue is that if you use a lot of opioids, for example, fentanyl concentration of 6 nanogram per ml, it really reduces the MAC bar even further, and you can achieve hemodynamic control in 50% of your patients with a concentration of SIVO of about 0.4%, which is quite low. But if we look at 0.4%, that tells us that 50% of your patients are probably awake. So if you give a lot of opioids, you're going to need very little agent in order to achieve hemodynamic stability. But you're running the risk that you're increasing awareness here. Therefore, with potent inhaled anesthetics, you should not use too many opioids and then reduce your agent concentration. I think you should try to aim for an agent concentration of 0.7 MAC, not lower than that. That is if you don't supplement with other agents, of course. But then it's going to be very difficult at this point to predict the probability of awareness. Another issue with opioids is hyperalgesia. There is a possibility that patients may develop more pain post-op if you have used too much opioid intra-op. But this is still an area of lots of research, and the last word has not been said about this issue. So we want unconsciousness and rapid emergence. So with potent inhaled anesthetics, we do that by monitoring the alveolar concentration, and we want it to be 0.7 MAC or slightly higher in combination with an opioid. With TIVA, we use a combination of propofol and opioid, but we can't measure anything. We can only use recommended administration schedules by other people. And in other words, we need pharmacokinetic, pharmacodynamic models in order to administer the correct dose and ensure unconsciousness. So pharmacokinetic and dynamic modeling is very important because it can determine the best combination of hypnotic agent and opioid that results in the fastest emergence from general anesthesia. And that's what NAVAt is all about. We want to navigate the anesthetic towards the optimal target. I'm going to give two examples of this pharmacokinetic dynamic modeling, one for a potent inhaled anesthetic and one for an intravenous agent. And this modeling has been done for propofol and L-fentanyl. This was done by Voigt in 1995. And he asked the question, what drug combination results in 50% probability of no response during abdominal surgery? And he defined no response as hemodynamic stability, no sweating or flushing, and no movement. And he found this dose response curve. And here we say, in the next slide, you see also the 50% probability of awake, the isobol for that, with a different concentration, of course, for plasma L-fentanyl and concentration. So now, based on that study, he did a computer analysis, and now he wanted to see what is the combination of agents that allow me the shortest wake-up time. Because you can see that with any of these drug combinations, you will get your desired response, 50% isobol of no response to a surgical stimulus. And here you have the 50% probability, the isobol here, for being awake. If you combine these two in one graph, you will see here the 50% probability of no response to surgical stimulus with a certain propofol and alfentanil concentration. And when you're at any point of this curve, you have the 50% probability of your desired response. When he superimposed that with the 50% probability isobol of awakening, which is this curve, the blue curve here, after a 15-minute infusion, he calculated by a computer analysis what time it took to go from anesthetized state to probability, 50% probability of awakening. And he found that for any combination of the agents, it took almost the same time, and the time here is represented in the vertical axis. So if you used a lot of propofol and very little alfentanil, it took slightly longer here, this vertical line here, it took slightly longer than if you used lower concentrations of propofol and higher doses of alfentanil. This was after 15-minute infusion, but if you do this for a 600-minute infusion, it becomes clear that the desired combination of the drugs is much closer to this point. So you should stay in this area of the isobol if you want fast awakening. This is kind of comparable to what we have called MAC and MAC awake. It's not the same, but it's kind of comparable. A similar model has been done for inhaled anesthetics and remifentanil in this case, but it could be done for any combination of agents. And here they looked at the response surface model with Remi and sevoflurane. It was a clinical study. They looked at the following stimulus-response combination, hypnosis. It went from a verbal order to shaking, and they looked for any response. And for immobility and autonomic reflex control, they used an electrical stimulus, and they looked for movement or a 10% increase in blood pressure and heart rate as a response. And this is what they found. Here they just plotted all the responses and non-responses with several combinations of remifentanil and sevo, very similar to the combination of alfentanil and propofol. And then they developed that into a surface response. And we are able to determine, on the left-hand side, you have the response of being aware. And on the right-hand side, you have the probability of non-response to the tetanic stimulation. And what he looked for was the 80% probability of responsiveness, and the other isobol here, the 95% isobol of response after tetanic stimulation. And then he also calculated the time it took to go from non-response to a tetanic stimulus to an 80% probability of responsiveness. And again, we find that the time to emergence is the shortest if you're in a very narrow range of your sevoflurane remifentanil combination. So here you see the time to awakening with different kind of concentrations of sevoflurane and remifentanil. Final question is what opioid to use, and I would say it depends. Obviously the short-acting agents are very titratable. However, there is no post-op analgesia, and they are more expensive in general. The longer-acting agent, you obviously lose the titratability, so they cannot be removed if the patient becomes hemodynamically unstable, hypotensive. But they do give you the initial build-up for providing post-op analgesia, and they are usually much cheaper also. So which agent to use really depends on your situation. I would say that if you can kind of predict what long-acting opioid you're going to need to provide post-op analgesia, that's what you can give during the anesthetic already. Then you can top that up with a short-acting agent to add some titratability. So in this first session, I defined the clinical goals of general anesthesia. I also presented how we achieve these goals with potent inhaled anesthetics versus DIVA, how the effects are potentiated by opioids, and the bonus of adding opioids, I think, is faster emergence. Thank you very much.